Okay. All right. Well, thank you. Hello. Welcome, everyone, to my talk today. My name is Dr. Danielle Ung, and I will be presenting on the topic of obsessive compulsive disorder, what the symptoms are of OCD, and how we can go about treating OCD using evidence-based treatment. My topic today, my lecture today, is very much aimed at individuals who either suspect that they have OCD, have heard about OCD, but don't know what OCD is, or they might know someone that they suspect has OCD and would like to learn more about that. And then also, they might want to also learn about how do they go about treating OCD? What are the first few steps to take in addressing this mental health disorder? And so this is the audience that I'm hoping to target today. Also, if there are any mental health providers who would like to learn more about OCD, this talk could also be very helpful and useful to you as well. So I'm going to be just going over some of the basics of what OCD is and the steps that you can take. And then I would recommend that if you're interested in learning more, to seek out a mental health professional who could help you answer some of those more in-depth questions. Okay. So again, thank you so much for everyone being here today. Before I start my lecture, I just want everyone to take note that the materials presented today are not intended to diagnose OCD or replace treatment from a mental health professional. If you believe that you have OCD or you know of someone who might have OCD, it's really important that you please consult a professional and also to seek treatment as well. All right, everyone. So before we get started, I want to share a little bit about who I am. So my name is Dr. Danielle Ung, and I am a licensed clinical psychologist in the state of Washington. I received my doctorates in clinical psychology at the University of South Florida in Tampa, Florida. I also completed my internship and my postdoc at Nationwide Children's Hospital in their autism center in Columbus, Ohio. So I've kind of been all around the map. I've had my specific training in OCD, anxiety, and autism. So I've got 15 years of clinical experience in those areas. And in fact, in my graduate school training, I actually received supervision and mentorship from someone who's very renowned in the OCD research world. I'm also an associate professor here at Bastyr University, where I'm also the director of clinical training for our master's students in counseling. So it's a pleasure of mine and I'm so grateful to be here today to share with you my knowledge of OCD. All right, so today this is a roadmap of what we'll be learning today. So the first the thing that I'll be talking about is what is OCD. So what are the obsessions and what are the compulsions as it's associated with OCD. Then I'm also going to be talking about what isn't OCD. There's a lot of misinformation that's out there about OCD, and there's a lot of stigma that has been associated with it. So I want to make sure that I clarify what those that I clarify any misconceptions about OCD. The next bit they'll be talking about is common obsessions and common compulsions symptoms. Although there are some themes that are common among all those who have OCD, there are also varying different types of obsessions and compulsions. So I'll speak of those in detail today. And then the next thing that I'll be talking about is now that one suspects that they might have OCD, how do they go about breaking that OCD cycle? So I'll be talking about some evidence-based treatments, is particularly the one called exposure with response prevention, which is the most evidence-based treatment that we have for OCD. And then I'll be talking about how do we go about understanding that cycle, how to break that cycle, and then providing some resources for those of you who would like to learn more about OCD and its treatment. And then, as I mentioned, at the end, I'll also be taking any questions that you might have. All right. So what is OCD? Okay, so what is obsessive compulsive disorder? So obsessive compulsive disorder contains both obsessions and compulsions. And the first bit we'll be talking about are the obsessions. So obsessions are these reoccurring and persistent, unwanted, intrusive thoughts, ideas, images, or impulses that the person might have. that often causes the individual a lot of anxiety or distress. They're often unpleasant. They might even seem silly or even embarrassing. And the person, in response to having these obsessions, they try to often ignore, suppress, or neutralize those obsessions. And some of these examples include like having intrusive thoughts of I'm dirty, I'm contaminated, I might get myself sick, I might get others sick. What if I do something that will hurt someone? That something bad will happen if I don't engage in a certain behavior, or what we'll talk about with the compulsions. Or often this feeling of I'm a bad or sinful person, that there's something wrong with me, and often needing to atone for that. Now, I want everyone to keep in mind here that most people we have intrusive thoughts. We sometimes have hundreds of intrusive thoughts in a day. The difference with obsessions is that oftentimes it's the value that we place on these thoughts. So an individual has OCD. I kind of call it like a sticky brain, where they often cling to the thoughts and often treat them as if they were real things, as if they were reality, as if they were to be true. And also, what the difference we see is that the frequency in which these intrusive thoughts occur and how time consuming, how distressing they are, also differentiates how it's different from just any thought that a person might have. We know that, again, these obsessions, these thoughts, these images, these ideas and impulses are very bothersome to that individual, causes them a lot of distress. Okay. The next thing we're talking about are compulsions. So compulsions are often in response to the obsessions, okay? They are repetitive, ritualistic behaviors that are aimed at preventing, reducing, or eliminating the distress that's caused by those obsessions, or they're often done to prevent the bad thing from happening. There's often this like strong urge to engage in these behaviors, and it may be even really difficult to stop this urge. That person actually, when prevented from engaging in those compulsions, might get very frustrated, worried, anxious, or even angry if they can't complete that compulsion. Now, oftentimes these compulsions are not in any way connected in a realistic way to that feared event or is clearly excessive. So, for example, a person might they might have the thought that, I don't know if I've locked my door, and they go to check if they've locked the door, and in fact they have, and then 5, 10 minutes later, they might find themselves asking themselves, did I lock the door? I'm not quite sure. And they might go and then try lock the door again. Now, we know that, with each succession locking of the door, checking the door, it doesn't actually prevent anything bad from happening. And so that's often where we see that it's not really connected in a realistic way to actually prevent something bad from happening. Some additional examples of that include like having those intrusive thoughts that I might be dirty, or that I might be getting sick, or that I might be contaminated, and engaging in excessive hand washing or needing to shower for hours at a time, multiple times during the day. Again, I mentioned making sure the door is locked, or that, for example, checking that the oven is off, despite having checked many times because of the fear that it might still be on, the person forgot to do so, and that something bad might happen to themselves or their home. Another example of a compulsion is counting a certain number of times. So it may be that the person, for example, before leaving the home might have to count to 10. They might have to tap or rub something a certain number of times in order to be able to leave their home, because they feel that this ritual might prevent something bad from happening, or that something bad might happen if they don't engage in those compulsions. Now, we know that these obsessions and compulsions are often very time consuming for an individual. And in fact, many people who have OCD are actually have very fair, what we call fair insight. They're fairly aware that these obsessions and compulsions may not actually be something that could actually um, prevent harm, but there's often this feeling, this urge that I need to do this. And um, and it often very much interferes greatly in their life. We know actually that, about 2 to 3% of people worldwide have OCD. And in the US in particular, we have about 2.5 million people who have OCD. So for those of you who suspect that you have OCD, please know that you're not alone. It occurs worldwide and happens to millions and millions of people here in this country. We know that we see OCD having higher rates in females more than males. In fact, 4 times greater in females than males. And it affects across all different age ranges. So usually the onset is between the ages of 8 to 12 years old, and men tend to actually have an earlier age of onset. Nearly about a quarter of them have an onset before the age of 10 years old. And we tend to see a gradual, symptoms tend to be gradual. So an individual might have some different kinds of types of obsessions and compulsions early on. There might be actually a waning of their symptoms. They're no longer having those symptoms, and then all of a sudden having these symptoms again. And the contents of the obsessions and the compulsions might greatly vary throughout their lifetime. We also know that OCD is often diagnosed or what we call comorbid with other symptoms, other diagnoses. And those diagnoses include anxiety disorders, depression, eating disorders, as well as other tic disorders. So again, as I mentioned, OCD is highly prevalent and often contains both obsessions and compulsions. Okay. So next, I want to share with you all what are some common obsessions and compulsions. So although the specific content of obsessions and compulsions do vary between individuals, there are certain themes that are more common, okay? And so I'll go ahead and share some common themes first with obsessions. So the first one is what we call contamination obsessions. And often this individual who has these contamination obsessions might be concerned with things like dirt, germs, or getting a certain illness. They also they might have these excessive concerns that they might be getting sick, that they have touched something that will make them sick, or that there's something in their environment in which it is making them sick. They also might have excessive concern with certain, for example, excessively bothered by sticky substances or residues, or also this excessive concern that they will get others sick by just simply touching them or bumping into them or spreading their germs to others. Again, the key here is that it's often excessive and unrealistic thoughts that one might actually be harming or spreading illness. The next one is aggression or harm to others in self-compulsion or obsessions. And this is a fear that the person might harm themselves, a fear that they might harm others. And in fact, this person does not want to do that, but they might have these intrusive images or even thoughts of creating harm to someone else, or that harm might come to them, right? They might even have violent or even horrific images of these bad things happening to themselves or others. Okay. The next one is sexual obsessions. And sexual obsessions are often including these forbidden or perverse sexual thoughts, images, and impulses, again, that a person may not want to have. They might have these intrusive images, thoughts of engaging sexual behaviors with others when in fact it causes them a lot of distress. They don't actually want to engage in them, but often feels like they have no control of when those images and thoughts occur. The next one is hoarding and saving obsessions. This includes things like fear of losing things. The person might feel like they have these thoughts that if I was to throw this away, something bad might happen. So they might save bits and pieces of papers or, for example, newspapers, or even in some cases with some clients that I've worked with, saving of food, even though that food is no longer something that they could eat and is good anymore, they feel like I just can't get rid of this. I have to keep that. It might be important later. The next one is what we call somatic obsessions. This is excessive concern with getting sick, with illness, or getting a disease. It could also include excessive concerns with certain body parts, constantly checking and examining to making sure that things are all in the right place, that there isn't a change in the appearance of certain parts of one's body. There might be a really hyper focus on a certain aspect of one's appearance. The next one is what we call superstitious or magical thinking obsessions. This can include things like a person might have these very lucky or unlucky numbers, but for example, must count to 10 before they leave the home, or they have to count the number of steps they take to leave the home, or even counting. I in the past have had a client who had to count all the tiles on the ceiling or on the floor before they could answer a question that I asked them. So a person with superstitious magical thinking, again, may have these lucky or unlucky numbers, colors, or words that they think that, they must engage in these behaviors or something bad might be happening. The next one is what we call religious obsessions. And this includes excessive concerns or fears of offending a religious objects. So often asking themselves, am I a moral person? Again, these are excessive. So like they're constantly thinking, is this right or wrong? Is this a moral behavior? Am I a moral person? And they will constantly ask themselves that question over and over again, or often have to seek reassurance from others to ask them, did I offend God? Did I offend a priest? Did I offend you about in the things that I've said or I've done? So this constant asking, excessive concern about offending someone. Okay. Some other ones that that aren't here but are also common is the fear of not saying the right thing, or the fear of doing things and just until it's right. So fear of, for example, these individuals will often doubt whether or not they've done the right thing or said the right thing, and will need to check with others to see if in fact they had done anything that was, for example, offensive. Okay. The next one we'll talk about, so the next group is our compulsions. Okay, so we'll start with the washing and cleaning. So um, uh, washing and cleaning compulsions include things like excessive or ritualized hand washing. So oftentimes this is in response to the obsession, the thought or the image, the obsession of I'm dirty, I'm not clean, and I need to wash my hands to get rid of the germs or any contaminants that are on them. But what they find that even after that hand washing is just not enough, and they feel the need to engage in that compulsion again to thoroughly clean their hands again. I've had clients in the past in which the cleaning has gone so excessive that they actually clean their hands until they're completely raw and they're bleeding, and yet still it doesn't feel clean enough. It can also include excessive or ritualized showering or bathing, toothbrushing, grooming. Again, you might have an individual who's taking showers for hours a day or eat for multiple times a day and just never feeling like they're clean enough or they've gotten rid of the contaminants that are on them. This also includes excessive cleaning of items. So cleaning of surfaces, for example, and even after cleaning of surfaces or even one's clothes, it just still feels dirty. And there's this need to again go back and clean that object again. Okay. The next one is the checking compulsions. So this can include, as I had mentioned, as some examples of that, is checking to make things sure that things are locked, making sure that things are turned off, checking that they didn't do anything terrible, that nothing bad will happen, checking that they didn't make a mistake. So, for example, I've had a clients in past or individuals in the past that I've known who are often seeking reassurance from a person saying, checking to say, did I make a mistake? Did anything bad happen? Did I harm you in any ways? And there's this constant repetitive nature of needing to check. Once is not enough. They constantly need that reassurance that in fact things are okay, that nothing bad will happen. The next one is a repeating ritual. And this can include things like needing to reread something over and over again till it feels right, or needing to rewrite something over and over again till it feels right. Um, I've had um, I've had clients in the past who oftentimes have difficulties, for example, turning in assignments because they feel like it just has to be right. They have to write the perfect sentence. That sentence just has to be right. That the assignment that they turn in has to be their absolute best work, and often have a fear of turning that in if it's not. So they often find themselves writing something, erasing again, writing again, and erasing it over again, or throwing away pieces of their assignments because they feel like it's just not perfect. There's often also a need to repeat a routine activity. So, for example, going in and out of doors, up and down from one chair, needing to repeat a routine a certain number of times, for example. The next one is a counting compulsion. So again, needing to count objects, count certain numbers, certain number of words. For example, counting the number of word times that the word the shows up on a page that they're reading. The next is ordering or arranging. So this is the need for symmetry or evening up, we call it. So for example, lining items up a certain number away or arranging them in a specific kind of pattern until it feels just right. And often these individuals will constantly be ordering or moving and rearranging things until it feels just right. But again, very temporary. And then they have to rearrange again, okay? Or constantly needing things to line up in a certain way. Okay? The next one is hoarding or saving compulsions. This includes difficulty throwing things away, saving bits of paper and string. And I want to make sure that I delineate this from someone who has a hobby in which they do collect things, but it gives them joy to do so. They actually have an interest that actually brings them pleasure and joy to collect these things, right? There is a sentimental value to them. And the difference, again, with compulsions is that it actually causes in quite a bit of distress. It's in response to an obsession that they have. It causes them a lot of distress to when they don't have these objects, right? And they have a very difficult time throwing them away because they think, for example, something bad might happen, or they might need those things later in the future. Okay. The next one is excessive superstitious behaviors. And this can include things like having to step on a certain number of spots on the floor, touching an object or a certain number of times, or engaging in a routine so that something bad might not happen. These individuals might actually have a very set routine that they do in response to the obsession to prevent bad things happening to themselves or to the other person. Okay. Oops. The next one are mental rituals, and this can include sometimes I kind of describe this as saying something to yourself over and over and over again in response to these intrusive thoughts. So the person might say, "I'm a good person, I'm a good person, I'm a good person," over and over again. They may also get engage in what we call ritualized praying. So they might when they have this thought that I'm a bad or sinful person, they might have where they find themselves needing to pray over and over to God to seek reassurance that in fact they are not a bad person. Okay, so these are things that often the person does that may not actually be seen as observable outward behaviors. The next one is needing to confess, tell, or ask. So this can include that if a person has felt like they've made a mistake or that they had, for example, weren't as honest, or that they had offended someone, there's this constant need to confess their mistakes to someone. Again, it's not just once, it's multiple times, needing to confess even just the littlest mistakes that someone has made, or even the need to tell someone and make sure someone has all the information that they have, or to ask this person repeatedly over and over again, seeking their reassurance that nothing bad, for example, nothing bad is going to happen to themselves, or that they're not sick, that they're not getting sick. This might actually, another example of this is that a person who might feel like they might be getting sick, or that they have an illness constantly, for example, going to the doctor, needing to call their doctor, asking the doctor, am I sick? Am I getting sick? I think I might be getting sick, and needing to tell about all their symptoms. Again, this excessive piece here is the key. The next bit is the need to do things until it feels just right, as I had mentioned. So, for example, needing to rearrange things in a certain way till it feels just right, or needing to say something over and over again until it feels right. And then the last one is the needing to touch, tap, or rub things in a certain way, a certain number of times, right? Until again, it feels just right. All right. So, I want also a few things to keep in mind here is that most people with OCD will have, again, multiple obsessions and compulsions, and they can change throughout a person's lifetime. We know that females tend to have more cleaning OCD, so more OCD that's a focus on needing things to be clean or to wash, to make sure things are not contaminated. Whereas males tend to have more of the forbidden thoughts, those sexual obsessions, and also feelings of symmetry, things needing to be lined up or have symmetry, OCD. So, what OCD isn't? And I think this is very important because it's important for me to go over this to first to destigmatize OCD and mental health, and also to clarify any misinformation that's about OCD. Oftentimes, I will say that when we talk about obsessions and compulsion, we talk about OCD in everyday terminology, it's often, I would say, the everyday language that we use OCD in is very different than the clinical term in which we as therapists and counselors and psychologists use. So the first bit is that obsessions and compulsions, in fact, do not give the person pleasure or is not enjoyed by the person. I've often hear a person says, like that person is very obsessive about that. They're really, they have an obsession with it. This is very different in OCD. The obsessions are very intrusive. They give the person a lot of displeasure and they do not enjoy them. In fact, that person finds it very anxiety provoking to have the obsessions. Next, OCD is not purposely caused by the person and it's not voluntary. It is not the fault of the person that they have OCD. This is oftentimes things that they do not want to engage in, but have a very strong urge to feel like they have to engage in these behaviors. Again, obsessions are not something that a person knows everything about. distressing thoughts that they have. And I also want to clarify that obsessions do not reveal or represent the person's hidden desires, wants, or needs. What often gives a person with OCD quite a lot of distress when they have the obsessions is this questioning of themselves of, is this actually what I want? Is this representative of what I want? And yet it causes them a lot of stress to have these sometimes very horrific thoughts or images that pop into their head. And I just want to first clarify here is that they, in fact, do not reveal or represent what a person actually wants. In fact, it may be the very opposite of what they want. I share with my clients that, in fact, a person who has OCD, who has a fear that they might engage in these behaviors, are actually the person that I suspect less of ever engaging, the unlikely person to engage in these behaviors because they have so much fear that they might engage in these behaviors. Okay. And then the next one is that OCD is very different from OCD personality disorder. So you often can hear of someone who is being OCD about something as being very perfectionistic or having this rigid control. And in fact, that's actually we have a separate diagnosis for that, and that's called OCD personality disorder. And it tends to be something that's actually lifelong that we see in earlier years. It has more to do with the person's temperament and their way of being. So this excessive pattern of needing things to be just right, things need to be perfect, right? And a need to have control over their behaviors in that way. Okay. All right. So what causes OCD? The thing is, we don't really know. There are a number of things that have been found to trigger or elicit to be associated with OCD. And what we know is that there isn't just one thing that causes it. Okay, so the first I'll talk about is genetics. So there has been quite a bit of area of research into this area of genetics. And what we do know is that those who develop OCD as a child, so we have what we call child onset OCD, tend to be 10 times more likely to have first degree relatives that have OCD symptoms. Okay, so that's where where we see a genetic link. We also see that in adults who have onset OCD, um, tend to be twice as likely to have first degree relatives who have OCD. So again, there is a lot of genetic research in this area. We do see a correlation or an association that occurs across family here. The next one is hormonal and neurotransmitter changes. In particular, we've seen that the neurotransmitter serotonin and glutamate seem to play a role in this area, but this is again a growing area of OCD research. The next one is brain anatomy. So we have seen that there have been findings that there are differences in the chemistry as well as the anatomy of the prefrontal cortex, the basal ganglia, and the thalamus. So certain aspects of the brain anatomy has been affected. And then, of course, there's environmental factors such as certain contaminants, for example, and also trauma that can also lead to OCD symptoms. Uniquely, there's an area of research of what we call pandas and pans, which is where we see that inflammation or infections can actually lead to some OCD symptoms or be associated with OCD symptoms. And in fact, I've had clients in the past, actually, I work with young children who parents have shared with me that their child, for example, had strep or had a bacterial infection. And the next day, it was like out of the blue, the child started having OCD symptoms. And what's also really interesting about this is that when these individuals are treated with antibiotics or anti-inflammatories, we actually see a lessening of OCD symptoms, not the elimination of OCD symptoms. So there might be a connection between inflammation, certain infections, certain bacterial and viral infections that might be contributing to some of these OCD symptoms. Okay. All right. And for those of you who would like to learn more about what causes OCD, I have a link right there for you to learn more. All right. So the impact of OCD, as I've mentioned, that OCD creates significant impacts on a person's life that can include things like avoiding certain people and places and things that trigger these obsessions and compulsions. It can be very isolating. That person often is fearful that they, for example, might embarrass themselves, or they might have these OCD symptoms that might come out of the blue or might be triggered in their environment, and they don't want others to know about that. And so they might isolate themselves out of fear of judgment or doing something that might be embarrassing. We also know that the amount of time that one engages in these obsessions and compulsions can have a detrimental effect on one's job, on their social interactions, as well as their academic performance as well. It can lead to things like poor concentrations, the ability to focus, to get tasks done in a timely manner. We also know that there are a high costs that can be associated with maintaining these OCD symptoms. For example, I've had some clients in the past in which that when they've had those hand washing obsessions and compulsions, family members are often sharing that they're spending gallons and gallons. They're spending a lot of money by buying gallons and gallons of soap, or spending high costs of for water, right? To maintain these OCD symptoms. We also know that OCD doesn't work in isolation. It often seeks the help of others around them to continue the OCD symptoms. And we see accommodations happening, for example, from families, from significant others, from partners, from friends, coworkers, who might be asked to participate as part of for example, the compulsions. Health impairments as well. So things like hand washing, for example, hand washing to the point where they're raw to prevent illness actually might have the counter effect, in where the person might actually be more likely to have an infection because there is that exposure of that skin, right? And so it actually might actually lead to more health impairments. And given the amount of time that one can engage in these obsessions and compulsions, it can very much lead to physical and emotional exhaustion, and many more other impacts as well. So the next bit we're going to talk about is the evidence-based treatment for OCD. We know that, if OCD is untreated, the course is usually chronic, and often what we see is a waxing and waning of symptoms as a result. And remission rates are much lower for those who have untreated OCD. Okay, so that's why it's very important for me to share with you a very evidence-based treatment called exposure with response prevention, that has a lot of research to show its efficacy. That in fact, it does very much work to help relieve the symptoms of OCD and improve the quality of one's quality of life. Okay. So the first thing that a person, in order to treat OCD, needs to understand is the OCD cycle. So what continues the OCD cycle, what I call reinforces the OCD cycle. And if you suspect that you have OCD, I would say this is kind of one of the first steps into treating OCD, is that becoming aware of your own OCD cycle. So the OCD cycle includes first identifying what are the obsessions. What are the intrusive, distressing thoughts, images, or urges that you have, or that the person might have, right? And as we know, when we have these obsessions, there's an increase in a sense of anxiety and distress, okay? Which then leads to the compulsions, which are these repetitive, ritualistic behaviors that are aimed at decreasing the anxiety caused by the obsessions, okay? But the issue with this is that the obsessions, the compulsions, I apologize, the compulsions only provide temporary relief from the obsessions. And then what will happen, it won't actually prevent the obsessions from happening again. The obsessions will then come back, right? Because it's actually being maintained by the compulsions, okay? So knowing this cycle is very important. Knowing what are the obsessions, for example, that you might have, and what are the corresponding compulsions to those obsessions can then lead you to help break the OCD cycle, okay? So the next slide here is about how to break the OCD cycle, knowing the tricks that OCD has, right? That the tricks that OCD has in that OCD cycle. So because we know that the compulsions are what actually reinforces, or what I say kind of encourage actually these obsessive thoughts to happen, right? The goal here is actually to reduce or eliminate the compulsions that the person engages in. Okay. So as I mentioned, the first step is to understand your OCD cycle. And the next bit is what I call externalizing OCD. And what I mean by OCD is that oftentimes obsessions and compulsions can almost feel like they're part of the person's being, their way of life, and who they are. And they actually become to define themselves in terms of their OCD. Externalizing OCD is seeing OCD as separate from who you are, that it is not all of who you are, and being able to label it, call it out when you see that it is occurring, when you see this cycle happening. So an example of this is I've had clients who are children who I will ask them, okay, so what's something you really dislike? What's something you really don't like at all that you find? They often make that face, that disgusting face when they have it, and that's and they often say words like broccoli. I really hate broccoli, or asparagus. And I'll say, okay, that's great. Let's call your OCD asparagus and broccoli. And every time you notice it coming up, let's label it. Let's say, oh, that's broccoli bothering me again. And in this way, it allows to see them as separate from who they are. It also helps them to destigmatize that word OCD as well. Okay. So first bit is to understand your OCD cycle and to call it out when you see it and to label it. Again, as I mentioned, because the compulsions are what maintain and reinforce the obsessions, and they only offer temporary relief. That is, they're simply a band-aid. They don't make the obsessions go away for a long period. They don't cure the individual of OCD. They only offer temporary relief. And then the cycle begins again. So because of that, what's part of the treatment of exposure response prevention, or what we call ERP, is to expose the person to the obsessions while preventing the compulsions from occurring, okay? And by doing so, the person learns that the compulsions don't actually prevent the bad things that happen. The obsessions will trick the person into thinking that if you don't engage in this compulsion, that bad thing's going to happen. So you have to engage in the compulsions. By showing the person that you can have the thought, you don't have to engage the compulsions, and that nothing bad will happen, and that you can handle this distress, you can handle that anxiety, you can cope with it, the person actually learns that you're right, these compulsions don't actually prevent the bad thing from happening, and I'm able to cope with these anxiety that the obsessions cause. And because of that, the obsessions actually tend to decrease because they no longer cause that high level of anxiety in that individual. This also encourages the person to build courage and empowers them to face more things that are difficult. Okay. So what I say here is habituation is the key when it comes to treating OCD symptoms, relieving OCD symptoms, and is the key and heart of ERP. But first, I want to direct everyone's attention to the OCD cycle, okay? And that's this line here that is indicated by this arrow that shows that when one has, for example, the obsession of feeling contaminated, okay, that anxiety will increase. And then the person engages in a compulsion of the ritualization, which then decreases. the anxiety. But then what the person is finding themselves, they're often in this roller coaster ride of obsessions and compulsions. Okay. So it doesn't cure, it doesn't fix, it doesn't treat OCD by actually engaging in the compulsions. So ERP instead, exposure response prevention, is about actually exposing that person to the things that causes them that expose them to the obsessions that causes the anxiety, and then not letting them engage in the compulsion so that the anxiety will actually naturally fall on its own. Actually, that when you expose a person over and over to something, it's kind of like when you learn how to ride a bike for the first time. You might get on that bike, you might fall, but you get back on it and you fall again. And over time, actually, that anxiety of getting back on the bike is not as hard. It's kind of this idea of facing one's own fears, right? And then gaining the courage to face one's own fears. And so when we allow that anxiety to naturally rise and fall without engaging in the compulsions, the anxiety tends to decrease. Okay. We see that decrease in anxiety. And I say to my clients, one thing that I have them keep in mind is that what goes up, that anxiety that's caused by the obsessions, will come down. What goes up will come down as long as we do not engage in those compulsions. Okay. I know that's easier said than done, but that is one of the key components here of exposure with response prevention. Right. So, some key takeaway messages here is that you are not alone. If you suspect that you have OCD or you know someone that has OCD, please know that you are not alone. OCD occurs worldwide and can have significant impact on a person's quality of life. OCD is not the fault of any person. These individuals often do not want to have these OCD symptoms, and they often feel like they cannot control them. Okay. It's important. The first step is to know your OCD cycle, know what are your obsessions, know what are the compulsions that correspond to those to those obsessions so that you are able to, if possible, prevent those compulsions. But again, it's easier said than done, right? So resisting compulsions is difficult. Absolutely understand that. That's why it's important that if you suspect if you have OCD, that you contact a mental health professional who can help you to improve those OCD symptoms. Okay. All right, so here are some resources that I provided here for you to have access to. So if you would like to learn more about OCD, please take a look at some of these fantastic resources. All right. Well, thank you so much, everyone, for being here today. Before I go into asking to see if anyone has any questions, I would like to just say that for any holistic mental health counseling or neuropathic health, that for any kind of any of these cares that you're interested in, please consider reaching out to us at Bastyr Center for Natural Health in Seattle or Bastyr University Clinic in San Diego. And if you are, again, interested in this areas to learn more, please visit our website at bastyrclinics.org. All right. Again, thank you so much for attending today, and I'll go ahead and take questions.